Well, we're going to finish out block 5 today. Actually, I don't know if I ever told you, I think at the very beginning of the semester when I first met you, I can tell you this outside of this, but Wednesday we don't have a lab. There's no lab for this block. Anyway, I'll talk to you later. Remember, we already started talking about the nerves, and now we're just looking at the arteries. Well, the arteries and veins of the thoracic wall run along with the nerve. Well, everywhere in the body that's true. But specifically when we talked about the costal groove that's behind the ribs, and you have a vein, artery, and nerve at each level. Kind of tucked up behind there somewhat. And so the arterial supply, if you blow it up on a transection like this, we're going to see that we have an aorta that provides what they call the posterior intercostal artery that comes around this way. And then it's also going to provide a posterior branch that goes out to supply the blood of the muscles and skin over the back. When we look at the anterior side, you also have this internal thoracic artery. So you have a posterior intercostal artery that comes off of the aorta, and then you have an anterior intercostal artery that comes off of the internal thoracic. And these little lobster claws that you see here mean that they have an anastomosis. They connect. So you get blood supply from the front and the back. So the $100 question that nobody in here probably remembers is, do you remember when I studied we looked at the branches off of the brachiocephalic trunk, or specifically off of the right subclavian? And I said, we don't need to know only the ones that are boxed on that picture. But there was one that I said, well, one of those is important because the internal thoracic comes off of that right subclavian and goes straight down the sternum on each side. And that's what's going to give the blood supply to the anterior portion of the thoracic wall. That's why we called that important earlier. I know some of y'all have no clue what you're talking about, but when you go back through the slides, you'll see what I mean. Okay, all of those main branches will just feed off. We're not going to name and label them. They will feed off of there and supply the anterior, lateral, posterior walls, skin, cutaneous branches, all of that off of there. Okay, so this kind of a wasted slide. This is just a blow up in case I want to talk about it more, but I think we got it. What is bolded on this picture for arteries is all we need to know. Fair enough? That there is an internal thoracic, and then there's a posterior intercostal and an anterior intercostal that meet up. Keep it simple. The veins have kind of a weird system associated with it. So anytime you have arterial going out, you got to have veins coming back. So all of the anterior costal areas will drain into the into the thoracic vein. What's called the anterior intercostal veins going into the internal thoracic. Oops. Posterior is a little different. So the posterior intercostal veins will empty into a crazy system called the azygos hemiazygos system. You can use either word. Sometimes we'll just say the azygos system. Or it's the hemiazygos, but they're the same, interchangeable there. So if we look at this picture, back here by the aorta, you have this venous system that we kind of see here in 3D that drains posterior intercostal veins. So the take home here, just to clear it up, it's an interesting system, but if you were asked by anybody and they said, well, where do the anterior intercostal veins drain? The thoracic vein, or internal thoracic vein. And then the posterior intercostal veins would drain into the azygos system before they ultimately make it back to the vena cavas. That's all we need to pick up on. Lymphatic, you keep hearing this ad nauseum where lymphatic drains. This one spells it out a little bit differently than we did before, because we're going to divide this and say, well, here's the belly button, the umbilicus. So the belly button, everything above the umbilicus, is going to drain to the axillary lymph nodes. Now, some of that drains to the parasternal lymph nodes, and we kind of know that when you talk about like diagnosing breast cancer and things. There's some parasternal lymph nodes, but most of it goes to the axillary lymph nodes. Most of the drainage below the umbilicus is going to go to the inguinal lymph nodes. Right, and then ultimately they're going to wind up back in our right and left lymphatic ducts. Or they're going to use those lymphatic ducts to get back into the venous circulation, right? Back up there by the subclavians. So this is what it looks like before we leave this topic of you have a vein, an artery, and a nerve. Now they kind of brought them out on the picture so that you could see that. If they tucked them back up underneath there on the picture, it wouldn't work as good. But just always remember, even for emergency medicine, when you start doing chest tubes and things, that you have a vein, an artery, and a nerve in that order. Vein, artery, nerve, at every level of your costals. And because of the way the nerve supply is set up, you also, if you're going to go into an intercostal space, you would want to go, above and below that area. Because remember when you look at a dermatome chart and it kind of overlaps, so you don't know if you're getting it exactly. So you normally go above and below two different intercostal spaces so that you can get in there. And, I said chest tubes and stuff. Chest tubes, you're probably not even numbing it up, right? You're not going to feel it. Well, there are instances where people get a chest tube, they're still awake, but if it's an emergency medicine thing, you're not going to stop and worry about the numbing them up. All right, thoracic diaphragm. We're working our way down. We're almost to the abdominal, and that tells me we're getting to the end of our slide counts. When you look at the thoracic diaphragm that we've discussed many times, it is dome-shaped, meaning that the dome, it's attached to the periphery of these costals, and so the dome, is this way. Like if this is a dome, it's at the bottom. And so when you actually take a breath, it goes down. Probably talking about this in respiratory. Right, you breathe in, expands. Right? But we're just going to look at the anatomy of the diaphragm. So you would say, yes, it's domed. That means its superior surface is convex. The inferior surface is concave. It is the main muscle of inspiration. I think you know by now. And it's attached all along the periphery. Then it has a central tendon that holds it all together. So if you were to look at it this way, this is an inferior view. So we're looking from down up. It has attachments along the costals. It also attaches down there at the sternum, down by the xiphoid process. And then back in the posterior side, posterior inferior, they have some connections called crura. And those are your vertebral attachments, where they kind of wrap around that vertebral column there. So those are the attachments at the periphery. Oops. Let's go back. At the middle there, we're going to see that you have all of this white area. That would be its attachment to the middle, but that's really just called the central tendon. So there's no true fixed attachment. Remember, that's moving. That central tendon's going up and down. Those muscles out here are contracting. And then we have to have openings in it, okay, where you have the inferior venous cable opening, you have an esophageal opening, and then the aorta. So these are all things that go from the thoracic cavity down into the abdominal cavity. Or you could say they're getting from the abdominal cavity up into the thoracic cavity, or more specifically the mediastinum of the thoracic cavity. So these are openings that allow that. This, I switched back because this is just a different view where you can only see the sides of the central tendon now because we're looking at a superior view. And you can orientate a little bit more because here's your vertebral body. Just in front of your vertebral bodies is always your aorta. Then you have your esophagus, and then the inferior vena cava. So what do you think this is? Pericardial sac, right? Your heart would be sitting out there. So that's what it kind of looks like. We're going to talk about the diaphragm. We bring up one issue here, paralysis of the diaphragm. You can actually have damage to the phrenic nerve on one side or the other. If you damage a phrenic nerve, you're going to lose the ability for that side of the diaphragm to contract. It normally won't affect the other half because that nerve supply is intact. So we're not talking necessarily about like a spinal cord injury of the spine. We're talking like peripheral, out damaging the vagus nerve itself. Somebody takes a box cutter to your neck or something. I don't know. Actually, I saw that. I'm rewatching Breaking Bad, and he cuts that dude's carotid artery with a box cutter. You ever seen it? It's one of the best shows ever. But rewatching it. I like it that much. It's been years though. I forgot something. So when you get into physical exam, another place you're going to hear these words: paradoxical movement. And you're going to have to be familiar with what that means. Paradoxical movement is basically an abnormal movement of the diaphragm. Like you take a inspiration chest film and your diaphragm looks funny. Both sides did not rise like they should. You know, obviously, yes, this person's having some trouble breathing. But you still got to figure out why. But if you hear paradoxical movement of the diaphragm, that means that one side is paralyzed. And what's going to happen is generally when your diaphragm descends, because you're doing an inspiration, taking a breath, both sides of your diaphragm there in red will go down lower. But if you have a paralyzed diaphragm, in this case, the right diaphragm is paralyzed. The phrenic nerve is damaged. The left is not. So the left is going to descend. But the right side now is going to go higher, or ascend, go more securely. Why would that be? This is why they call it paradoxical movement. If it's paralyzed, should it move at all? No. So why would it? I'm being rhetorical. I'm just trying to make you think. You have abdominal pressure, right? You've taken a crap in the last few days. You know that. Well, no, it's fine. You have abdominal pressures. Well, your abdominal pressures also are, remember, your thoracic and your abdominal area is separated by your diaphragm. But if one side of your diaphragm contracts and the other doesn't, all your bowels that are there and things are going to get pushed up because there's abdominal pressure. So this diaphragm descends, and basically your bowel contents are going to push that side of the diaphragm up every time they breathe. And so that's called paradoxical movement. So anytime you have paradoxical movement, think hemidiaphragm paralysis. One side of your diaphragm is paralyzed. In radiology, you can try to figure out which side that is. But I'll tell you this, if one side of the diaphragm is way higher than the other, that's the side that's paralyzed. That's why I just explained all that to you, so you won't miss that later. All right, you're going to love this. Subdivisions of the thorax. Now in every class, cardiology, with A&P 1 and 2, you'll hear these words like mediastinum. And they just say, oh, well, that's part of the mediastinum. Well, right now we're going to learn what's in each part of the mediastinum. But the way they divide it up makes it a little more simplistic. If you listen to the way that I look at it, maybe the way I look at it doesn't always make sense, but hopefully I'll give you a good way to remember all these different things because of the way they set it up. Now you have pulmonary cavities in the thoracic cavity. That's your lungs. In between your lungs, do you have other organs, viscera going through there? Esophagus, aorta, lymph nodes, your trachea, all sorts of stuff right in there. So we want to know specifically, picture, when you're studying the mediastinum, think about radiology, but because you're going to have to find things within there. This is going to help you to find where the lesion is, like in radiology. It's also, you need to think like a surgeon. Remember back to the triangles of the neck? Think of these as like the surgeon. Except in this case, we're going to look a little deeper into how they divide it up. So you have two main divisions. There is a superior mediastinum and an inferior mediastinum. Okay, the superior mediastinum is basically the area that's behind the manubrium. So if you picture going from the manubrium back, right, everything that's behind that is the superior mediastinum. The inferior mediastinum is down here below the body and xiphoid process of the sternum. They're going to divide this up a little funny. The superior mediastinum is divided into planes from front to back, from anterior to posterior. The inferior mediastinum is divided up anterior, middle, and posterior. Stay with me, because when you work through it, at first, especially the inferior, seems a little more confusing. But the superior is kind of easier because they named them for what they consider to be in each plane. These are just lists you have to know, not just from my class, but for other classes there. You have a glandular plane. What do we think is going to be in there? Glands. A venous plane, probably some venous structures. Arterial nervous, visceral nervous, meaning you have those and the nerves that go through there, like the phrenic nerve goes through there, the transient, and a lymphatic plane. And just like they're named, you will see that. So the glandular plane is the most anterior plane, and it's what's going to contain the thyroid, some lymph glands, and if you have anything left of your thymus there, that's where it would be found. When you go back posterior to that, you have the venous plane, which contains your left and right brachiocephalic veins, and then you have your superior vena cava and the arch of the azygos. Or the azygos is what's draining the posterior intercostal veins. So the top of that is found. Now keep in mind, we're going to have some overlap with structures. We haven't seen it yet, but we will. Arterial nervous plane is the arch of the aorta and any branches that come off of there, but the main ones are brachiocephalic, left common, and the left subclavian. That leaves out the right side, I get that. But it's because of the way this area is situated. That's what they list as being in the arterial nervous plane. And then vagus and phrenic. Vagus and phrenic nerves go through the arterial nervous plane. You know, you got a picture, you're cutting into somebody, dissecting back, and you get to those. Both of those nerves go through the neck, but they do not innervate anything in the neck. They are considered transient at this point. Now, does the vagus innervate anything that would be considered in the neck? Yeah. Remember, it innervates the larynx. But it goes through this plane. It goes through this plane, the arterial nervous plane, and then it comes back. It provides a recurrent laryngeal branch that comes back to the larynx after this. That's why I said you got to think like a surgeon. The visceral nervous plane would be where we find the viscera, where we have the trachea, the esophagus, and that's where we see that left recurrent laryngeal nerve come back up. So another way to think about it, to remember, is the recurrent laryngeal nerve is a branch of vagus that comes back up. But if you looked at it in its larynx attachment, where it ends, you wouldn't see it above that in there. Makes sense? You would see vagus, phrenics coming down, but you wouldn't see the recurrent laryngeal go any higher than the larynx. So that's how they separate it. Then the last one here is the lymphatic plane. That's just back to our same picture we always see about the lymphatic plane, but really it only includes, by definition, for superior mediastinum, is the thoracic duct, or that left lymphatic duct. All right, so I told you the inferior's a little bit tougher, but I'm going to try and explain things. Now I'm going to mention 2 slides to you, and then I'm not going to be asking you on the test. I'm going to save it for when you get to radiology and they start discussing it. But in radiology, they're going to talk about the red and the blue side of the inferior mediastinum. So we're below the manubrium now, posterior to the body of the sternum. You have what's called the right side, which is the end of the inferior mediastinum. I'm going to start over. The inferior mediastinum can be divided up 2 different ways. I always call this the radiology way. And then there's the textbook way. Even though you learn them both in radiology and other classes, it's just a way of remembering that the right side of the inferior mediastinum is generally called the blue side. If it's called the blue side, what do you think mostly is on that side of it? veins. And we can look and say, well, is that what it says? Yeah. Oh, look, the arch of the azygos, the superior vena cava, and the right atrium. Now you're supposed to throw out, wait, Mr. Wright, you just told us the arch of the azygos was somewhere else, right? Did I? Right? That's part of the superior mediastinum. In other words, the arch of the azygos is found a little bit of it in both of them. That's the confusing part. But let's go back. So that's your blue side. Like I said, these blue slide, red side, I'm just teaching you so you've seen them. The red side, then we're going to have our arterial supply. So we would find like the left common carotid, the subclavian, the arch of the aorta, red. So for these two slides, what I want you to know is that there's a red and a blue side. You already made the jump that if it's the red side, it's probably arterial. I don't need you to list for me what's in the red and blue side for this exam, but you're going to learn that in radiology. You're going to be looking at some chest films. They're kind of color-coded red and blue. If you never tried to read a chest x-ray, especially on a test, you're looking at the anterior, posterior views, you're looking at the scenario you were given, and you're really trying to pinpoint where something is. And you're going to get very specific because there's different diagnoses. And so when you do radiology here, it's very important to understand these mediastinal contents because you can localize where something is. Is that in the lung? Is that in the mediastinum? Is that a nervous problem? Is that a lymph node? And you're going to have to find those things. So, it'll be good. Okay, so here's the way we really look at the inferior mediastinum, but it's divided up into anterior, middle, and posterior. So instead of saying, I want to keep us on track because I brought up all that red blue stuff, what we said is the superior mediastinum has planes. 1, 2, 3, 4, 5 planes going from front to back, right? Glandular on back. The inferior mediastinum below the manubrium has 3 different areas. They didn't call them planes, they just called them anterior, middle, and posterior mediastinum instead of saying planes. So what we're going to find in the anterior mediastinum is mostly like some connective tissues, a few blood vessels, some lymph nodes. If you have any remnant of your thymus, you might find some there. So just a few things. The middle mediastinum makes it very easy because the only thing we're going to find in the middle mediastinum is the heart and the pericardium. That's it. So your heart's right in the middle of the mediastinum. And there are a lot of other things in the inferior mediastinum, but they're in the posterior compartment. So if you like to think the way that I do, because I like to cut my losses and try to figure out what's the differences, when it comes to the inferior mediastinum, if we just have some lymph nodes, a few blood vessels in the anterior, we just have the heart in the middle, and you're answering questions on where something else is in the inferior mediastinum, where are the odds that it's at? The posterior mediastinum, because look at the list for the posterior. One of those areas when I study, I study the exception in this case rather than the rule of going, okay, well, almost everything's in the posterior mediastinum. What's not? Make sense to some of y'all maybe? So I'm not going to read through those. It's just about everything that you can think of. And then we get to the abdomen. Sorry, I don't know where to bring my phone. Y'all understand, I get a text, I'm like, who's texting me today? At least. Regional anatomy of the abdomen. If we look at this, I need to start watching that edge, huh? I thought about that over the weekend, in case y'all didn't know. When I stumbled on the edge here, I caught myself, and I threw out a lesson man was on the ground. And I thought, man, that made you sound like you thought very highly of yourself. No. I was just happy I didn't fall. You know. See, I come in and I correct what I regretted saying over the weekend about a lesser man, and then I just had the thought when I said it, yeah, but a lesser man would have fallen. Should have fallen. No, as a student, if an instructor fell off the podium, I'm with you. I'd die. Talk about falling out of your seat laughing. I mean, I'd try to get out of, are you okay, like you with your buddies. My first thought's going to be a chuckle, because I watched too many of those videos. People walking on ice. Regional anatomy of the abdominal area. Alright, yeah, take a deep breath. How's that new coffee place down there? I don't drink coffee, but it's good? Better than Starbucks? Starbucks. I thought about coming in and telling y'all this morning I can't stand Starbucks people, but that would include my daughters and stuff, so I can't say that. I can't stand the Starbucks people that buy Starbucks as they come off the island. When you leave Mustang Island coming back from Port Aransas, there's a Starbucks they just built right on the bay there. And the people don't know that they want to go to the last second. They're all driving off the island, it's packed traffic. All of a sudden all these brake lights come on a 55-mile-an-hour area, and they stay in the lane instead of getting into the turn. And you're about to hit them. And I almost do it every time. And I'm like, you need to look up where your Starbucks is before you head there. There's no way I would wait in line for 20 minutes for a cup of coffee. No, Dr. Pepper? Yeah, I'll wait. Coffee. What makes the world go around? I drink coffee if I'm cold or I need caffeine. The only way I'm drinking coffee is lukewarm and I'm slamming it like I'm at the bar drinking. I don't like the taste of it, but that caffeine sure feels good. Here we go. Lat muscles of the abdomen. I had to give y'all something. Y'all were all yawning and stuff. I had to talk about something in between the blocks. Okay, if we look at the abdominal muscles, what we're mainly going to look at is what's the structure of the abdominal wall. You have three different muscle layers, an external, an internal, and transverse abdominal. Does that sound familiar? That's pretty similar to what we saw up here on the thoracic cavity. So they're in that way. So if somebody said, well, somebody took a knife, shot you with an arrow, whatever that might be, through your abdominal wall, that's the order it would go through. External, internal, your transverse abdominal. Right? Anteriorly, though, we have the rectus abdominis, which runs vertically on the front of the abdomen. So if you took this picture, and you'll probably see this in other classes, this is how that wall is set up, where you have the skin out here, and then you have your external. So this would be, well, that's not anterior, it'd be superficial, because you could be on a different area. So this would be the deep side. And so you have the external oblique, the internal oblique, then transverse abdominis. Out here, this is called what's called the superficial fatty layer, but somebody took credit for it, and it's Camper's fascia. And then kind of deep and in between the different layers, the deeper fascias are called Scarpa's fascia. Why is that? I do not know. Why? I don't, it's Scarpa's fascia, that's who dissected it out and named it. I do know how to remember where the Camper's fascia is, because the more that you go camping and sit on your butt, right, to get your campers a look fat, the big belly. Campers. You'll hear more about those in relation to when you need to, if you ever need to. Right. Now we all know that you can get a 6-pack, an 8-pack, or you can go to the store and get a 12-pack. However you like to think about your packs. Right? That's because you have vertical muscles called the rectus abdominis here. I know that we're familiar with these, but what we may not realize is the external, internal, and transverse oblique muscles have a fascia around them, and all of that is going to come together and form what's called the rectus sheath. This kind of goes around them. And so we see that here. This is part of that rectus sheath at each level. So that if you strengthen these muscles, tighten down your abdomen, it'll start to have that 6-pack look because you have that rectus sheath in between those nice muscle belly bulks that you can make stand out. Now it's not depicted here, even though I'm going to kind of draw it down here. There is a muscle that's absent in about 20% of people. I'm about to give some people an excuse. So down the middle of your rectus abdominis, you have the linea alba. And if the linea alba is very tight, you can see how it holds your abdomen in better. It'd make your six-pack. It's right down the middle, right down through, connected to those rectus sheaths. So in most people, there's a muscle called pyramidalis, a very small muscle, and it kind of keeps tension on that linea alba. And so I'm giving you an excuse. If you're one of those people who say, whether you are or not, I work out every day, I can't get that six-pack, just tell people, well, I got shortened in life. I'm missing the pyramidalis. You'll probably never know whether you are or not. The only thing I can say to that is you never know whether you're doing the work to get to the six-pack. But use it however you want. Nobody's finding that funny. It's been a long time since I had any type of six-pack. Long time. I'm thinking basic training. It's overrated. Vasculature of the abdominal cavity. This is another area that I want you to do your best, even though you look tired today, even after a low task weekend. You must have been studying something, must have been biochem. That you took the weekend off. The party. I went to Port Aransas again. And I didn't go. Oh, I thought you said you went.
I went last on 4th of July.
You went this weekend? Oh. That's awesome. No, I went down to pick up the golf cart, bring it back to his ranch. And mow grass. I didn't go down to the farm. If anybody needs info, especially about beach areas, Corpus is not worth it when 30 minutes, you can drive 30 minutes more and get to Port Aransas. Corpus is dirty, and beaches in Texas are dirty in general. People don't realize Corpus is not really on the ocean. I mean, yeah, I get it, it's an ocean, but it's in a huge bay. So all you get are these brown, muddy waves with lots of jellyfish in them. You gotta go around Port Aransas, which is open to the rest of the call. Anyway, just some advice. When it gets close to Christmas, I won't have y'all in my class, but you got kids, you need to find all those activities some people like to do, like pumpkin patches and apple orchards with all sorts of holiday stuff. You let me know, because I know where they're all at. Okay, you're going to look at the way we break down these arterial as coming off the abdominal aorta. There are a lot of vessels that go to the abdominal area, but I'm going to point out exactly which ones I expect you to know in the schematics, that kind of thing. So we'll pay off to listen to me here so you know this. The abdominal aorta gives off parietal and visceral branches. We're not going to discuss a lot of the parietal branches. Parietal branches are going to areas like the overlying skin, right? But we're going to look at what goes to the viscera, like the kidneys, the adrenal glands, that kind of stuff. So the main ones, these are the only ones that we're going to find and label on the diagram. The celiac trunk, superior mesenteric, suprarenal, renal arteries, gonadal, and inferior. I know you're like, well, you just read a long list. That's because you don't know how many there are actually that we could name. But I'm going to get even more specific. You're going to know exactly what you need to know before we do it. I did that on purpose. I'll show you one. Alright. So I don't like schematics. I like it for figuring out where things are at, but I don't like to give you a question how do you label the actual schematic. But some people really use these. But what I'll do for you is come to the schematic and kind of simplify it for you. Even though it's already numbered, I'm going to show you. Remember, I don't really, the parietal branches, great. You don't have to memorize those. They're going to cutaneous areas. But we want to look at the visceral branches that come off of the abdominal aorta. The first one is the celiac trunk. So I'm going to circle on any arterial diagrams you see. I'm going to circle the ones that you should be able to find. There we go. So there's your celiac trunk, superior mesenteric. We have suprarenal, renal, gonadal, and inferior mesenteric. And that's it. Other than the fact that we're going to discuss the common hepatic, because we're going to look at the liver's blood supply again, okay? Like portal system versus, so we're going to look at the branches of the celiac trunk. But I'm talking about the labeling of things. Now, where are you at? See, I just cut out a bunch that you didn't know were there. Right? And they're in that order. We're doing them in the order. So that's when we come back to this picture and go, well, that's pretty busy. It is, but it includes the thoracic area. We already studied thoracic. It includes the aorta areas all the way through. But now we're just using it to say, can we identify the branches of the abdominal aorta? And that's what I want you to do. And so if we come over here and say, you can look for, this is the the aorta, the hiatus for the aorta there, the opening in the diaphragm. Just below that, as soon as we come past that area, we have what's called the celiac trunk. And we'll get into what the celiac trunk means in a second. And then the next one we're going to see is the superior mesenteric. And then we have our right and left renal arteries. We have our right and left gonadal arteries. Some are paired, some aren't. And then we have the last one here is the inferior mesenteric. I want you, I think this is even a study picture. Those ones that are boxed, I want you to be able to identify. For later, and for other things. When we look at these different branches and what they supply, like I said, sometimes they'll be paired, sometimes they weren't. Anytime you think about mesenteric, bowels, the superior mesenteric artery, vein, nerve, always, when you hear that, always goes to the small intestine part of the large. The inferior mesenteric arteries, veins, nerves, always, anytime you hear inferior mesenteric, think the rest of the large intestine and colon. That would fit. So superior mesenteric, kind of small intestine stuff. Inferior mesenteric is mainly the colon. Blood supply, venous, nerves. It's all the same. Okay, so we have to break down the celiac trunk specifically because of the problems that we can have. And because we've already studied GI, and I hope by now most of y'all are kind of familiar, because y'all did GI at Rosario. So you kind of already understand portal hypertension, but I'm still going to go back through it again. Give you the parts and pieces. So if it's familiar and you're like, wow, we're going back to basics. I already got this and I already tested on it. Great. We're looking at it again from the anatomy one side because it's an important area. So as you look at the celiac trunk, we're going to have three branches. The left gastric, splenic, and common hepatic. Right. We're going to focus in on the common hepatic, but there is a left gastric branch that comes off of the celiac trunk, meaning it's going to gastric, stomach, esophagus. There is a splenic branch. Guess where that's going? To the spleen. And then our one we really want to discuss is the common hepatic, mainly the fact that it goes to the liver. But it hits the liver, the gallbladder, because the gallbladder is tucked up under the liver, part of the stomach, duodenum, pancreas, greater of it. It goes to a lot of areas. Main thing about the common hepatic artery is it provides oxygenated blood to the liver. Red blood, straight to the liver. Just like every other organ, it gets a branch in there that goes to it. We'll come back and talk about portal hypertension towards the end. But the superior, sorry, we got a break on. Oh, let's just do it there. Let's take a break. I'm not getting anywhere fast. We're about done now. 3 more minutes. Could have just kept going, I guess. I can probably do that. Well, thing to do if you just want to hang out is to rent a hotel room down on the Riverwalk. It's all good at. There's not as many kid activities as you want or something. So there's Divine Acres, which is an apple orchard. They do much Christmas stuff. No, that's Divine. Christmas tree farm, and all of those have, my neighbor says, corn maze out of Tonja. I recommend you best I don't know. That's a lot. Yeah, and just don't take somebody who's gonna get, that body who gets drunk, I'm just gonna go through the wall with that. Don't take something that gets bad. You can feel out. You can get lost.
You do want to get through that focus here.
There's more. Just you gotta tell me what you want to do with these people and do it.
We've been out there. Everybody over there.
You don't see a bunch. I think they may be one. Churches around San Antonio. We're not like we show up and take pictures. That's about it. Maybe one activity. If you go out to there's 9 acres of apple. I can't remember if they go something. I know they do Christmas. But you can go out at Christmas and have a take the Santa. They got the crazy goats that climb trees and stuff like that. They have a lot of kids that I can get you some things. I think I meant to mention that, but you weren't there. Y'all aren't always in the house, especially let me know when it's over. I like to drink the fresh apple pie cider out there. It's freezing like that.
That's what I mean. Just like,
I don't like it.
I've seen something left over or something.
There's a huge, I'll get you.
Whether it be a drink. Thanks for well, you never know.
My older brother his job in Dallas and moving to some random small town in New Mexico. High school history teacher have the rest of my time to myself. I'm gonna go 4 days a week. came up, I thought the same thing. That was change kind of makes sense. She's gonna pick up those back. She's like, so long as it's really voluntarily versus like always doing it. Like, like, yeah, actually that sounds right. So she's taking she's taking a water park, swimming every day, and she's going to clothes, shopping clothes, and all the stuff she's gonna do. I think we did it all back. I was at their way too. Everybody's fucking No, it's not. Marathon?
I'm not saying I'm ready for it.
I just need
Like I said, I committed. That's not a party. 2 days before it, like on Thursday, the dude's like, do you want to go road race? I didn't prepare for it at all, other than military TT.
the whiskey berries, the drive around it, half mile drive around it. 50 But so 31 miles, it's a half mile, and I had like a perfect size.
At least the wine's got. Actually, I can say this. I was thinking, there's 30,000 people running. 35. So when I tell people that I finished it, I have this picture on my I love football. And it says, finished, and you're like, 5 hours and 5 minutes. And I think people go, you're so slow, even if you look at the numbers though, say I didn't train, you're like, okay, so how, 1,000 men in my age group, I came in with 3,000 something. I'm like, that's about 25%. I was doing reading with pressure. You gotta read the document. There's a lot of people all I know is I didn't find it. Alright, let's finish up. I have to look at this. Oh. I know, for a second I thought one of y'all sent a message or something. Thought your message was up. Alright, superior mesenteric artery, having its branches. When you look at everywhere that I said earlier, just categorize the superior mesenteric being on the higher side of the GI system, meaning, basically your small intestine. Now I gave you the 3 words. It does do part of the pancreas, but duodenum, jejunum, and ileum are all small intestine. So I just grouped them into being small intestine. The ascending and transverse colon, so I said part of the colon. Then the inferior mesenteric is going to do the other portion. In other words, the transverse, rest of the transverse, down to the descending colon, sigmoid colon, and rectum, down your Kilman parts. On the venous side, we're not going to get a whole lot in. Actually, we're going to focus in on the hepatic portal system again. But we also have to realize blood from the abdominal viscera, the pelvic viscera, and the abdominal wall all get back to the heart by going via the inferior vena cava. So all the blood that comes to the abdominal wall, all the blood that comes to most of the viscera in the abdominal area, pelvic viscera, all goes back to the heart via the inferior vena cava, except blood that went to the GI tract. Because we know that that blood doesn't go directly into the inferior vena cava. So if it's the GI tract, that means that blood, for the most part, is going to the liver using the common hepatic portal vein. So I'm going to leave it at this. Most of the veins that enter the inferior vena cava, they're coming from these parietal/visceral branches of the aorta. They're named the same as their arteries. That's all I'm going to say. We're not going to label them. We could, but here's what I'm trying to say. If there is a renal artery, there's a renal vein. If there's a suprarenal or gonadal artery, there's a gonadal vein. Hard stop. Got it? Because I like to focus more on, well, what about the hepatic portal vein? Because that's what gets you money for diagnosis and stuff, right? So if we realize all the rest of the blood in the abdominal goes to the inferior vena cava except this, that makes it easier way to remember. And so the liver receives oxygenated blood coming off of the celiac trunk. Remember the celiac trunk provided the common hepatic artery? So it's going to receive oxygenated blood from there. It's also going to receive purple blood from the portal vein. Right? So blood that goes to the GI tract, sometimes they'll throw in their spleen, pancreas, gallbladder, great. I want you to think GI tract. Are the spleen, are the pancreas and the gallbladder accessory structures of the GI tract? Yeah. But just think bowels. So most of the blood coming from the bowels goes back to the hepatic portal vein. So we're delivering essentially deoxygenated blood to the liver. Y'all have talked about this in other classes, right? So I'm not crazy that you have. Right, so we know that from the GI talk that you had in there. So I'm defining once again a portal system. Generally in the body, if blood flows through an artery to like your fingers, it goes through that capillary system, and Ruggiero throws out all sorts of pressures and figuring out osmotic. That's going to come back up in renal too. But trying to dig on it a little bit there. Wasn't really digging on it, it stated the fact. But at the capillary, there's going to be an exchange, right, where oxygenated blood is going to carry nutrients, or waste products, back towards the heart as venous blood. But if a blood supply goes to a capillary system, and then it goes from there to another capillary system before it goes back to the heart, that's called a portal system. There are only two in the body. The main one is the hepatic portal system. Because in the hepatic portal, we had oxygenated blood going to the GI tract. Superior mesenteric artery, inferior mesenteric artery, they provided oxygenated blood to the GI tract. Your hamburger was there, and you took in nutrients. And so the GI tract used that oxygen. Right? It needs oxygen too. But at the same time, you're pulling nutrients into that blood that's flowing. But that's nutrients are actually going into the hepatic portal vein that goes to the liver. Because everything that you take into the GI system has to go through the liver before it goes to general circulation. Because the liver is where we metabolize and change things. I know I'm talking about stuff you already know. So you would say all the blood going to the liver from the GI tract through the hepatic portal vein is deoxygenated, nutrient-rich blood. That's going to go to the liver. So we can see the two portal systems. We have a hepatic portal system, hypophyseal portal system. At this point for us, the hypophyseal portal system doesn't really matter. just the hepatic one. Now, when you look at how this is happening, you have veins that are coming together from the splenic, different areas, but they're always going to meet up with the common, or the, let's call it, sorry, the hepatic portal vein to go into the liver. So it then goes into the liver and goes into those sinusoids. And I know that y'all are like, yeah, I know the three parts of these sinusoids. And for now, for us, all we need to realize is that deoxygenated nutrient-rich blood is coming from the liver. Oxygenated normal blood with no nutrients in it is coming from the common hepatic artery. So you have blue blood and red blood mixing in the sinusoids. So the sinusoids would be said to be purple. It's a mixture. Because sinusoids receive deoxygenated and oxygenated blood. And they mix together in the sinusoids. The rest of that's, you've already done in A&P I. So what happens after that? That means you have to have it leave the liver. After it's been processed, it drains out. It's going to go through the hepatic veins back into the inferior vena cava. Okay, so where you're going to get confused in here in other classes is when you go, you confuse the fact that the hepatic veins are not the same as the hepatic portal vein. That's why I've been saying it over and over and over. But I guarantee you, later on somewhere, you're going to read too fast and make that wrongly distinction that someone's going to ask you, where do you find deoxygenated, nutrient-rich blood? And you're going to jump hepatic vein. And you're going to be 100% wrong. Because that's the hepatic portal vein that has nutrient-rich blood. You see now why I'm beating it up so much? Things you already know. I'm trying to help you later that you don't make that mistake. Because I've done it before in my mind thinking, start calling things the hepatic vein and not. Always say portal vein. Portal vein. It'll remind you. Okay. We've heard of hemorrhoids. Maybe you've heard of esophageal varices. These are all part of the portal system. So there is an alternate way. Blood must make it back to the inferior vena cava for you to continue living. Because once all of your nutrients that you've eaten, tried to take in, have to go through the liver first. But what if your liver's damaged? Can blood still can some of that nutrient-rich blood get back into general circulation? Yes. But that's not going to be a good thing. Right? That is due to the fact that on areas, if you looked at the common or the hepatic portal vein, you'll see that it has some tributaries that come off of it. And normally they're not open. They're kind of, just picture them collapsing down, like you picture the eustachian tube. Kind of collapse down. No blood's really going through them normally. But if you go up here and block the liver, okay, where the hepatic portal vein enters, if you block it, and by blocking it, I mean that you have hepatic cirrhosis, any type of liver damage, you have a resistance that's going to develop. Blood cannot flow through the liver. You're going to develop what's called, anybody want to throw it out there? Portal hypertension. Portal hypertension is going to force blood back into these portal veins and into these tributaries that normally don't go, are not used, and it's an alternate way for blood to get out of this system. But that's going, now you're going to be diagnosing people because it's going to start draining in areas called the esophageal veins, and when you look at the periumbilical veins, you look at veins down by your anal sphincter. We're going to have names for these, and they're abnormal names. So, and that's a whole talk. I already said this. These are just alternate ways that blood could get back, nutrient-rich blood could get back to your generalized system. It's not going to be very optimal, though. Some of this goes back to when you were a fetus. And things we don't always use anymore, but they're there, and you can recannulate them. You can reopen those. Like I keep saying, that's not going to be a good thing. So if you have, I want to make this clarification too. There are esophageal veins what do these esophageal veins do for you normally? They drain away the blood supply that came to the esophagus. Right? An esophageal varice is a very thin-walled vein. An esophageal varice is due to the fact that the portal vein has some tributaries that go near the esophagus. They're little submucosal veins. Normally, they do not drain blood away from the esophagus. That's the job of the esophageal veins. But if you back up, if you block the liver and you back up into these portal veins, you will develop esophageal varices, which are little dilated veins down in your esophagus. Right? And that's, like I said, that will not be good. If you think about alcoholics and things, an alcoholic or a hepatitis victim, drug user, that kind of thing, they will become dilated and tortuous, and they will start to bleed. And if you, the only way you're going to see this is to go look through endoscopy, and you see that they have things have gone through and eroded. So those veins become dilated because they're kind of getting engorged, and then things go by there and rub on them, or you start coughing too much, that kind of stuff, and you get esophageal varices that start to bleed. That's why somebody who's a chronic alcoholic, homeless, that kind of thing, comes in off the street. Sorry, I'm giving you all a lot on this because it comes up a lot. Is you're going to get esophageal, or maybe Rogerio talked about it. You're going to get esophageal varices. You could bleed and die. And you're often going to catch this in people who are alcoholics, but don't know they're bleeding. Hey, if you've ever done a cold blood test, this is a great reason for a cold blood test on an individual, because if you didn't know this, if you say somebody's has rectal bleeding, the first question is, was it bright red blood, or did you pick that up on like fecal occult testing? If it's bright red blood, that means it's down by the anal sphincter. It's close. You know, it's like within a finger's reach. Hey, get used to it. It's your job too now. But if it's dark blood, you're not going to see it because feces is dark. And so nowadays it's like the act of Congress to do a fecal occult blood test. It used to be every room you went in, you just did it real quick. It doesn't make any sense. They send you to the lab now when they already had their finger up your butt, and they could have just put it on the paper and you're done. They make people go get a stool. Y'all notice that? They don't do it in the room a lot of times anymore, in civilian side especially. They'll send you to the lab. That's always fun. Or the outside lab. Anyway, fecal occult blood means blood is coming from somewhere and it's making it into your GI tract. Esophageal varices is a good reason why that might happen. If somebody's anemic and they have fecal occult blood, you know, they may not have cancer and stuff, but they have a lot of bleeding, and it can cause them to become very anemic before they even know it. You can die from these things. So, enough about esophageal varices. The only way you'll know is to take a look, though, with an endoscopy. But most homeless alcoholics are not showing up at your ER until an ambulance for you. So anywhere that they have these tributaries, they can become backed up. Let's leave it at that. So you can have dilated pericardial umbilical veins, which produces what you'll hear later is called caput medusa. Looks like a bunch of snakes. Varices in the rectal area, we term them as hemorrhoids. Just for clarification, hemorrhoids are not always from these varices. You can have hemorrhoids from other veins or arterial supplies down that area too, right? But you can have them from this. So this is caput medusae. So if you have scarring or fibrosis of the liver, that's going to allow your portal vein not to be able to bring blood to the liver, and so that's going to back up. This would be severe. If you see this in a patient, that's pretty severe. Because it's backing up into all these pericardial umbilical veins that existed when you were like a fetus, and you'll start to see this on the patient. Okay? I've never seen anybody with full caput medusae in person as a patient. Of course, I don't work in a lot of ERs, but that's not that uncommon. Okay? So I gave you a scenario just for fun here as to finish it up. So a 47-year-old man with 7-year history of hepatic cirrhosis due to chronic hepatitis B infection. Then you gave him a physical exam, had firm liver, mild splenomegaly, mildly, I don't think they're mildly torturous, but that's what they call them, mildly tortuous veins on his abdominal wall, especially above his umbilicus. So if you didn't know, most people do not have that. I have to say that because somebody might have that and just think everybody does. If you have that, talk to me offline. Yeah, go see a provider, but talk to me offline because we need to get to, you can go back with me to the ER where my wife's at right now. I'll take you with me. Anyway, that's what it looks like. Obviously, I'm not going to give you a scenario of exam, but that's an example of the kind of things you see. And while it seems so clear cut on here, when you start reading these scenarios later, you're going to be like, 47-year-old man, and I hear my brain going, okay, 40, what's common in the 40s, what's common in the 40s, you're building a differential, you're going to use this. 7-year history, does it matter how long it's been? Is it acute, is it chronic? These are things, you're going to do this for the rest of your life. If you've never done medicine before, you're going to be reading these going, okay, what are they talking, hepatic cirrhosis, oh shit, I know something about cirrhosis, and it's, oh, you told me he has chronic hep B infection. Does that make it a different answer than hep C? You know, if you're not thinking that later, you can come back and tell me I'm wrong, but I guarantee you will be. You get to the physical exam, and that really just starts to throw you off, because you can get firm liver from a lot of stuff. Then they like to throw in mild. I want you to make it easy for me. Give me torturous. Anyway. Mild spleen enlargement. That's it. For block 5. It's crazy. I don't like getting to this point. But see, y'all are excited because after this test and 2 more, y'all get to move on and go do great things. Guess what I get to do? Start it over. What if the next class sucks? I always worry about that. Because every now and then you get one. And they just have no sense of humor. They have no ability to do anything but stare at you. That hasn't happened in a while. But I'm due for it. I think the next class I get like that though, I'm going to act like I'm back in the military again. You know I'm not going to do that. Y'all have a good day.